What's up, fellow Ambossians? I'm Dr. Zeb, here to get the most out of this question with you in the next 7 minutes by covering test-taking strategies, high-yield concepts, and bonus questions at the end. I know you're very busy studying, so let's jump right in. We first need to determine our task by reading the lead-in. Which of the following is the most likely cause of this patient's hypercalcemia? Alright, now I'm primed for a pathophysiology question. In a real clinical setting, it's important to focus on the patient's history and examination before jumping to diagnostics. But for time board questions, I like to read the sentence before to look for confirmatory findings or even a diagnosis if I'm lucky to save time. An X-ray of the chest shows bilateral hilar lymphadenopathy. Okay, bilateral hilar lymphadenopathy is an important clue that should narrow down our differentials to which conditions. That's right, sarcoidosis, infections typically fungal, like histoplasmosis, blastomycosis, or coccidioidomycosis. Tuberculosis is usually unilateral. Mediastinal tumors like lymphoma, or even some pneumoconiosis, so dust inhalation diseases like silicosis or berylliosis. So now it's time to put on our thinking caps and break out those illness scripts. Which of these differentials is associated with hypercalcemia? Definitely sarcoidosis. But actually, any chronic granulomatous disease, including lymphomas and even some systemic fungal infections or pneumoconiosis, could cause it as well. So let's look for additional features to help narrow down the diagnosis. A 35-year-old woman with hypertension comes to the physician because of a 4-month history of progressive fatigue, shortness of breath, constipation, and a non-productive cough. Current medications include hydrochlorothiazide and a multivitamin. So to continue our clinical reasoning, so far we have 2 non-specific findings: hypertension controlled by a thiazide diuretic and worsening fatigue. 1 sign of hypercalcemia, constipation. Remember, too much calcium equals too little caca. 2 respiratory symptoms, shortness of breath and cough. And I'm also paying attention to the age and sex. These often provide important clues to a condition. And that's it. There's no history of travel, occupation, or other exposure to indicate pneumoconiosis or an infectious cause. There are no additional constitutional symptoms such as weight loss, low-grade fever, and night sweats to indicate cancer. Now, the info in the stem alone doesn't rule out these conditions, but for exam purposes, if it was important for ruling in a condition, in other words, a pertinent positive, then the MBME would have included it. So, as a systemic disorder that affects the lungs, is associated with hypercalcemia, and occurs most often in younger to middle-aged women, we can hypothesize that sarcoidosis is the most likely diagnosis. And if you think back in your pathology, you'll remember that chronic sarcoidosis is characterized by non-caseating granulomas. Hey bro, want some cheese? No thanks, I'm a non-caseating granuloma. These granulomas harbor activated macrophages that produce 1-alpha hydroxylase. This enzyme is responsible for converting calcidiol, or 25-hydroxyvitamin D, to the metabolically active calcitriol, also known as 1,25-dihydroxyvitamin D,
or 1,25-dihydroxycholecalciferol, or...
Geez, how many names does this vitamin have? Normally this happens in the kidneys. Calcitriol then increases intestinal and renal calcium absorption. Hey, non-caseating, what do you call a vitamin D who's on trial for kidnapping calcium? What? Calcitriol. But in sarcoidosis, it occurs ectopically in activated macrophages, which can ultimately lead to hypercalcemia. If you ever need any help with clinical reasoning, I recommend utilizing the key terms or attending tip at AMBOSS questions in practice mode. Fighting through the question with the help of these tools will make the content more memorable than just guessing. Now that we've answered the question, let's see if we can find a match. Voila, there it is. To save time and my nerves, I would normally mark it and move on because it matched our reasoning, so we don't have to rule out other options. But let's say you weren't 100% sure, or you're reviewing. When reviewing questions, it's important to briefly reflect and connect concepts to strengthen your knowledge and identify any gaps, so you'll be more prepared for similar questions on exam day. Let's do that now. Parathyroid hormone-related protein production. This is a good consideration since it can also cause hypercalcemia, particularly as a paraneoplastic syndrome of squamous cell carcinomas. If you remember, PTH and PTH-related protein increase serum calcium by triggering its resorption from bone and kidney and activating 1-alpha hydroxylase to create more calcitriol. Although this patient has symptoms that could match squamous cell lung cancer, coughing, we'd expect a solitary hilar nodule in the X-ray instead. With this patient's hypertension, chronic kidney disease would be a good differential to consider. But what happens to calcitriol and phosphate with chronic kidney disease? That's right, renal calcitriol production is impaired, meaning less calcium absorption, and reduced phosphate excretion leads to an excess serum phosphate that binds circulating calcium. So we'd actually expect hypocalcemia, not hypercalcemia. As for the last three, you'd be right to consider them as causes of hypercalcemia. A parathyroid adenoma induces hypercalcemia by excess PTH, as we just spoke about with PTH-related protein. Although quite rare and not high yield, vitamin A toxicity from excessive supplementation could disrupt calcium homeostasis, leading to hypercalcemia. As for thiazides, in the early distal convoluted tubule, they inhibit sodium chloride cotransporters, which leads to a loss of sodium and an increase in renal calcium resorption to compensate. But none of these explain the respiratory symptoms or bilateral hilar lymphadenopathy. Also, thiazide-induced hypercalcemia is usually milder, so less than 11.5 mg per deciliter. Continuing our reflective practice, let's briefly consider what other questions could appear on the exam for a stem like this. Other correct options could be elevated calcitriol, compensatory decreased PTH, or hyperphosphatemia. We could have been asked for sarcoidosis histopathology such as non-caseating granulomas, asteroid bodies, or Schaumann bodies. They could have asked about a further sarcoidosis finding like uveitis or skin lesions, or even the diagnosis of sarcoidosis itself. Ectopic 1-alpha hydroxylase production is also the cause of hypercalcemia induced by other chronic granulomatous diseases like TB as well as lymphomas. So in reality, we could have answered the question correctly without even diagnosing sarcoidosis. But hey, hopefully you learned or reinforced something useful. Any of these concepts could appear on your exam, so when you study, try to actively recall like this to be even more prepared. You can read more about sarcoidosis and differentials in this AMBOSS article. Let us know in the comments below if you have any other ideas for a good lead-in question. So to recap, the key takeaways of this question are: 1. Formulate differentials for hypercalcemia and know their pathophysiology. 2. Know that chronic granulomatous conditions like sarcoidosis and lymphomas induce hypercalcemia by expressing ectopic 1-alpha hydroxylase, an enzyme that converts calcidiol to calcitriol, which increases calcium absorption. 3. Identify sarcoidosis based on respiratory symptoms, signs of hypercalcemia such as constipation, and bilateral hilar lymphadenopathy. Alright, that's it for this video. For another high-yield topic that you'll definitely see on step 1, let us know in the YouTube comments if you found this video helpful and would like to see more. If we get enough interest, I'd be happy to continue them. Remember, hard work pays off, so keep it up, stay positive, you've got this.